Well, good afternoon. It's a pleasure again on a Tuesday at noon to have our lunch and learn. Thank you for the very positive feedback. I want to thank our technical crew led by Sean Ewens and Sarah Olison. We could not do this without you. We hope that these lunch and learn conferences have been helpful to you. We really miss being together, but during these COVID times, at least this gives us an opportunity to say hello to one another. You're welcome to put something in the chat and to see our faces. I hope that you've learned something during these meetings. It's really my pleasure today to introduce our speaker. I've known this speaker for many, many years. He's been a colleague, a friend. As I was thinking back, he and I have done many things around the country. I don't think he's ever said no to me, and I hope I've never said no to him. And Dr. Pat Duff is a professor at the University of Florida. I asked him to share a few things that I could say about him. I don't know how many more times I will have the opportunity to work with him or to introduce him, but as you will tell, we admire one another. Dr. Duff grew up in the suburbs of DC. He did his undergraduate work at Harvard, his medical school at Georgetown, and his residency at Walter Reed, where I actually did my internship. He did his fellowship at the University of Texas in San Antonio. And when I say these places, it reminds me of some really giants in our field who have worked there. He had 21 years of military service, and thank you for your service. And I think I probably met Pat during that period of time. Then he's been at the University of Florida for 31 years, as residency director for 21 years, and then the dean for student affairs for 19 years. One of the medical students that's there is from Sarasota. And she asked me one day, do you know a Pat Duff? He gave a lecture and it was very nice. And I just smiled and said, things are coming around. His research interest, as you'll find out, is an infectious disease. But the best thing I can say about Pat is he's a family man. I've had him speak at more than one conference, and before I could get up and go say thank you, he was back in his car and heading back to Gainesville so he could see his family. So it's a great honor and a pleasure to introduce to you Professor Pat Duff, and he's going to talk to us about COVID-19 infection in pregnancy. Pat?
Washington, thank you for that gracious introduction, and even more important, thanks for your friendship through the years. I have a sobering subject to review with everyone today, and you only have to look at the newspapers and the evening news to realize what an ominous problem COVID-19 is. And I'd like to try to approach this subject in the following ways. Learn a little bit about the microbiology and the epidemiology of COVID-19, then discuss how it presents clinically, 3 basic distinct clinical presentations: how we diagnose it, what we know now about managing the condition, and then certain special considerations in pregnancy. What struck me when I first started to read about this condition and was asked to do a short paper for OBGYN management about it was that I didn't know a lot of the language that was being used, which is basically, I guess, language that's been around for years in the public health literature, but it's certainly not, these aren't things that we typically talk about on a day-to-day basis in OBGYN. Quarantine versus containment, and mitigation strategies, and the whole concept of the reproduction number and flattening the curve. And these were all new concepts, but so important in the present pandemic. The virus that causes COVID-19 is a novel new coronavirus. Now, there are other coronaviruses, as we'll see in a moment. This virus, we think, started in animals, and the virus has considerable genetic similarity with the viruses that cause SARS and MERS, which were very serious illnesses at the time, but they sort of have paled in significance to the problem we now face with COVID. As you see in this diagram, the virus has these very distinct spike proteins on its surface, and those are the proteins that attach to the ACE2 receptors in various organs of the body. I mentioned MERS and SARS as key coronaviruses, but interestingly, the common cold. The common cold is a coronavirus, but certainly the consequences of the common cold are not nearly so dramatic as with COVID-19. This virus was first identified in Wuhan, China in December of this past year. And it started at a specific site in Wuhan, which is the Hunan seafood wholesale market. The initial epicenter for this infection, of course, was in China, then subsequently South Korea, Iran, and Italy, and then France and Spain. On March 11th of 2020, the World Health Organization declared that the COVID infection was in truth an actual pandemic. And unfortunately, the epicenter for the pandemic today is now the United States. And I thought you would be interested in this telling summary table. If you look worldwide, as of 11:30 this morning, there were 47.5 million cases of COVID-19 that had been reported worldwide and 1.2 million deaths. In the United States, again, as of 11:30 today, there have been 9.2 million reported cases and sadly, 230,383 individuals who have died as a result of this infection. We have 4% of the world's population and 25% of the world's deaths as a result of COVID-19. And the question is, I think, why are our outcomes so poor in the United States? We are an incredibly sophisticated and affluent country with wonderful medical knowledge, and yet we've had very inconsistent messages about COVID-19 from both national and local leaders. Our public health system has not been very well funded in recent years. We still don't really have a clear systematic testing and contact tracing protocol in place. And as depicted in these photographs, there are individuals among us who have made very poor decisions, such as in Florida, crowding the beaches, crowding the bars, and in South Dakota, that motorcycle rally that was held earlier in the summer with 350,000 people crowded together in a relatively small town, essentially none of them wearing masks. This is an incredibly infectious virus, and it is deadly. It is not just a form of the flu. Influenza A and B has a case for fatality rate of about 0.1%. The case fatality rate for COVID-19 is 1.5 to 2% on average, but the range goes from 1 to 13%. I think it is fair to say that the predominant method by which this virus is transmitted is by close exposure to respiratory droplets. But there is also evidence to suggest that the virus is contained in aerosolized particles and can spread for a farther distance than you would expect just from respiratory droplets alone. The CDC now has redefined the concept of what constitutes a significant exposure to COVID. In the initial phases of the pandemic, the definition was 15 minutes of sustained contact with an infected person and you are not wearing a mask. The current definition is 15 minutes of cumulative contact and you're not wearing a mask. The photograph here actually is of two culture plates, and we're looking here at bacterial growth, but the principle is the same. Viruses obviously aren't going to grow on these culture plates. And on the left, you have an example of the bacteria that would grow when someone exposes a culture plate to respiratory droplets and isn't wearing a mask. On the right, you see the pretty much absence of bacterial growth when person is wearing a mask and coughs or sneezes. We do have evidence telling us that this virus can be transmitted by close surface-to-hand contact with infected respiratory secretions. And then hand-to-face contact is also important. I'm sure all of you have been surprised to realize, if you just stop and think in the course of a day, how many times you inadvertently touch hands to your face. This concept of the reproduction number, the issue is if you are infected and someone is exposed to you, how many other people are going to get infected? And the reproduction number for viral influenza hovers at about 1. For COVID-19, it's 2 to 3. And just by comparison, for Ebola virus, it's about 2 to 10. So the reproduction number is significantly higher. So the virus is incredibly contagious and incredibly dangerous. The virus can persist in your respiratory secretions for up to about 13 days after you may have had complete resolution of any clinical symptoms. Now, the sad feature of this whole pandemic is the number of people who have developed severe or critical illness. We know that there are several very well-defined risk factors for severe or critical illness. One is being over the age of 60. Obesity, because of the compromised respiratory effects, I think, of obesity. If you have cardiopulmonary disease, you're at increased risk, or diabetes. Workers in essential occupations, such as healthcare workers, such as those who work in the food industry or in the public transportation industry, are at increased risk. And because Black patients and Hispanic patients are disproportionately represented in those essential industries, they have paid a devastating or suffered a devastating toll with this pandemic. Prisoners are at increased risk, obviously because of the close confines in which they're held. And just last week, there were a couple of interesting papers in the New England Journal of Medicine that pointed out some of the key genetic factors that may be related to enhanced susceptibility to infection. If you have blood group A, you're at increased risk for severe or critical illness. Conversely, if you have blood group O, you're somewhat protected. And then there's a gene that's been described at that specific locus depicted there that is important in encoding a protein that's involved in ciliary action. And the gene is also helps to mediate immunologic synapses with antigen-presenting cells. And the ultimate effect of deficits of this gene is that you end up with increased susceptibility to cytokine storm, which really seems to be the ultimate sort of final common pathway to a terrible outcome in this setting. Sobering statistic for all of us sitting here today is that frontline healthcare workers have a 3- to 4-fold risk of contracting infection compared to those who don't work in this high-risk industry. Now, this pie chart, I think, depicts the key epidemiologic feature of this disease. Most patients that contract this illness are either asymptomatic or have, at worst, a mild illness. So that's about 85% of individuals. That's the good news. But the bad news is that about 10% of people who acquire COVID infection develop severe disease, and about 5% develop critical life-threatening illness. For mild illness, I think all of us are familiar with how this would typically present. Fever, myalgias, arthralgias, sore throat, and this distinctive lack of taste and smell. Patients with mild illness typically have a non-productive cough. They may have mild dyspnea, and they can even have some GI manifestations, notably diarrhea. Severe illness or critical illness is a totally different ballgame. The dyspnea is severe. You may have a secondary bacterial pneumonia. ARDS is a big part of this picture. Some patients progress to multi-organ failure and septic shock in the setting of COVID infection. What about diagnosis? For a number of months, the standard diagnostic test, the gold standard, I think, was using PCR and applying that to secretions obtained from a nasopharyngeal swab. And I'm sure some of you have had that and found that to be at least mildly uncomfortable. I actually thought the person was trying to biopsy the temporal lobe of my brain. I had no idea the nasopharynx went back so far. But fortunately now, I think we're going to move to a new gold standard where we use saliva as opposed to the nasopharyngeal swab. And again, PCR is the testing modality of choice. In patients who test negative but have pretty much classic symptomatology, the CT scan also can be very, very helpful. And the classic findings you see on CT scanning are these densities within the lung and a so-called ground glass appearance to the lung parenchyma. In the differential diagnosis of COVID-19 infection, we certainly have to think about viral influenza, namely influenza A and B, atypical pneumonia caused by mycoplasma organisms could present in this same way, and particularly in a patient who might be HIV infected, pneumocystis jirovecii infection could mimic a lot of the symptomatology we just described. Now, there is a burgeoning literature on COVID in pregnancy, and I certainly am not going to bore you with going through study after study. What I've tried to do is pull together in a few simple slides what seemed to me to be kind of the essence of information that we now have about COVID in pregnancy. First of all, I think we could say that pregnant women are not more likely to acquire infection than someone who isn't pregnant. I don't think that pregnant women are necessarily more likely to develop severe illness compared to non-pregnant women or men, even though you might think that they would be at greater risk because of the compromised respiratory dynamics related to the expanding uterus. We don't have any definitive evidence that the virus is teratogenic, but I would say that up to this point, most of the information about COVID in pregnancy has come from women who were infected in the latter half of pregnancy as opposed to the early months of pregnancy. There is clearly an increased risk of preterm delivery, but that's less so due to just spontaneous preterm labor and more because the mother's condition is deteriorating and the obstetricians intervened for maternal reasons, even though the baby was in fact preterm. There is clearly an increased risk of cesarean delivery in the setting of COVID infection. And again, I think that's largely because in many instances, obstetricians were intervening preterm because the mother was critically ill. She had an unfavorable cervix, not really favorable for induction, and cesarean delivery was the most rapid way to get the baby out. Perinatal transmission seems to be very, very rare. And I wanted to refer to you, there is now a national pediatric registry that's specifically examining mother-infant dyads and asking the question, what's the likelihood of the neonate being infected? And when I last looked at this, courtesy of our neonatal director, there had been 2,400 cases of maternal infection reported to the registry, and 1.8% of neonates were positive. So, practical issues. What can we do to take care of the patients that are infected? If the patient is asymptomatic, but we document that they are infected, the key, of course, is self-isolation for 14 days. And where'd that 14 days come from? Well, it comes in part from the incubation period of the virus, and it comes from the fact that the virus seems to persist in respiratory secretions for up to 2 weeks. In the patient who's mildly ill, I think they would be better off not being near the hospital or the emergency department. So self-isolation, try to maximize their nutrition and their hydration. Things grandma told us when we were younger, when we felt sick, is rest and sleep, and certainly use of acetaminophen or NSAIDs such as ibuprofen for control of fever, myalgias, and arthralgias. For the more severely ill patient, this individual certainly needs to be hospitalized. They may need respiratory support. Well, I should say they often will need respiratory support, and that could range from something as simple as oxygen administered by face mask to mechanical ventilation. They have to be monitored for and treated for multi-organ failure. And an interesting fact that's emerged from the literature is that patients hospitalized with severe illness seem to be at significantly increased risk for venous thromboembolic events such as DVT and pulmonary embolism. So we have to try to prophylax against those events. As I mentioned earlier, many of these patients will get secondary bacterial infections, particularly pneumonias. So we need appropriate antibiotic therapy for the most common pathogens. In this setting, ceftriaxone is certainly an excellent antibiotic to cover a broad range of pathogens. Azithromycin to pick up atypical organisms. Vancomycin, perhaps, if we're concerned about staphylococcal infection. You've read in the papers about remdesivir, which is it's not a new, it was actually a drug that was originally developed, I believe, to try to treat Ebola virus infection, and didn't work very well for that, but it seems to have, I think it would be fair to say, modest activity against COVID. Now, dexamethasone, I think, seems like a very important drug for us to be aware of. And it's interesting, there's sort of a paradox to this. In the studies of dexamethasone, the drug did not work well in patients who had only mild illness. And the thought there is, in the mild form of the disease, you actually don't want to suppress the immune system. You want to allow the immune system to function naturally, and dexamethasone, of course, does suppress the immune system. But conversely, in the later stages of the illness, when you're severely or critically ill and your body is being ravaged by the cytokine storm, then dexamethasone really exerts its remarkable protective effect. I know that all of you are familiar with this final drug that I listed here. That's the antibody cocktail that President Trump received a couple of weeks ago at Walter Reed. It contains antibodies. It contains 2 separate monoclonal antibodies. In preliminary trials, that drug or that product seemed to be moderately effective. Within the last week, the company suspended its trial of this drug in critically ill patients. It's continuing the trial in patients who are less severely ill. The concern in the critically ill patients is that there were some untoward side effects that the company wanted to stop and investigate more thoroughly. What about in our labor and delivery suites? I think the standard of care today would be to screen all patients in advance of an anticipated admission, for example, like a scheduled cesarean, and at the time, or an induction, and then screening others at the time of admission. The availability of the saliva test and the rapid turnaround time that test permits is really a great help to us here. Certainly restricting and screening visitors, usually limiting to one consistent person throughout the patient's hospitalization. And then patients that are clearly infected should be, to the greatest extent possible, cared for in the special rooms that have negative airflow. The patient and her visitor certainly should be wearing a mask. Upon admission, the visitor should continue to wear the mask. The mask may be tough to keep in place for the laboring patient. For any patient who's clearly infected or is under investigation for active infection, we need to be sure that we're wearing our personal protective equipment. And interestingly, I think the public health authorities have gone back and forth on this, but I know that the current position, I believe, of the CDC and certainly of our neonatal unit here at UF is that they do allow the mother or the baby to room in with the mother if the mother is not seriously ill, reasoning that, of course, when the mother is discharged, the baby's going to be with her in close confines at home. There are some general preventive measures that are important for all of us to put into place, and I know you've heard these over and over again in the evening news, but certainly wearing a properly fitted mask that covers your nose and your mouth, washing your hands carefully and thoroughly and frequently, obviously with approximately 20 seconds per wash, maintaining appropriate social distancing, which is a minimum of 6 feet under ordinary circumstances, avoiding large crowds like crowded football stadiums, for example, or crowded motorcycle rallies. And if you are going to be in a large crowd, wearing a mask would certainly be a very thoughtful thing to do. And of course, all of our patients should be vaccinated, and ourselves should be vaccinated for the seasonal influenza. There are some circumstances that require greater social distancing. For example, singing is a great source of spreading respiratory droplets, and 6 feet distance is probably not enough if you're near someone who's singing. Similarly, woodwinds and particularly brass instruments generate many respiratory droplets that can travel surprising distances. You've probably noticed at some of the football games on television that most band members are separated from one another distance-wise, and they also have little masks, if you will, over the blowhorn of their instrument. Working out in gyms is also a place where you certainly can spread this virus for a greater distance, and people cycling together like in this class here, that's way too close together for people working hard and breathing heavily. I want to address something that's been in the newspapers the last week or so, and that's this concept of herd immunity. And we certainly learned about that in medical school, and we were learning about rubella and rubeola and measles and mumps and chickenpox. But the herd immunity concept is not applicable to the current pandemic. Why? Because we can't protect adequately the most vulnerable members of our society. And in fact, too many Americans are vulnerable by virtue of their age or comorbidities, notably diabetes and obesity. Unlike rubella or chickenpox or rubeola, patients who get COVID-19 have an alarmingly high mortality rate if they become seriously ill. Another problem with this concept of herd immunity is that there's an uncertain duration of immunity in those who develop antibody. For example, the fact that you have a cold, say last week, that doesn't necessarily protect you against getting a common cold a month from now. And it's by no means clear that the duration of immunity for COVID infection is going to last an extended period of time. After all, we have to be revaccinated each year for viral influenza A and B. Thomas Frieden, who was the former director of the CDC, had a sobering quote that I read in our newspaper this weekend, and he said, "The road to herd immunity passes through the graveyard." Certainly, we all are looking forward to the development of an effective vaccine. There are more than 50 different vaccines in preparation/trial now. There are some major issues related to the vaccine. One is the simple concept of safety. We want the vaccine to be appropriately immunogenic to elicit a robust antibody response, but we don't want it to be so immunogenic that it actually causes serious disease. That, by the way, is one of the major problems with the development of an effective vaccine against HIV infection. We want a vaccine that will elicit such a robust antibody response that the duration of immunity will be long-lasting. Key question, the early vaccines, the ones that seem most readily poised to be introduced commercially, are requiring 2 injections. Ideally, it would be better in terms of patient compliance if you only had to administer the vaccine once. A huge public health and ethical issue will be priorities for vaccination. Who should be first in line to receive the vaccines? And then, the early candidates for the vaccine have posed some interesting transportation and storage problems in that they have to be kept at very, very low temperatures during transport. So storing the vaccine, transporting it, and distributing it in an ethical and efficient and effective manner is quite a logistic challenge. So those were the things that I wanted to say with respect to this virus. I would close by saying the bottom line is that this virus is highly contagious and incredibly dangerous. The mortality rate is alarmingly high, even in seemingly healthy young adults. Prevention is the key. And the key to prevention is proper use of a mask, social distancing, careful hand washing, and hope that the vaccine will soon be available and can be distributed widely. I would be very happy to entertain any questions or comments that you might have. And thank you very much for letting me share the lunch hour with you.
Well, Pat, thank you so much. You certainly have fulfilled what we wanted to have done. Any questions? I'll get started with one, and if Sean or Sarah can look through the chat for me, that would be helpful. So what's the bottom line on the symptomatic patient who is pregnant, who comes to the emergency room, who then is admitted? What's the current knowledge and understanding of ICU admission, ventilation, and death in that patient?
So Washington, the patient's pregnant, but not necessarily in labor.
Correct.
So I think you would treat that patient as you would a non-pregnant patient, namely hospitalized, probably in the ICU, begin with face mask, oxygen, hopefully not having to progress to ventilation. I think the early trend was intervening early with mechanical ventilation. I think the trend now among the intensivists is to try to delay that a little bit longer, not so long that you end up losing a patient, of course. The ventilation often is in the prone position because that seems to be more effective. And again, PPE for the caregivers and negative airflow rooms to protect others. And again, sad to say, as I pointed out, some of those patients, because of the seriousness of their illness, the cytokine storm, they may well end up with preterm labor. and or maternal deterioration that requires intervention. And then we're going to be in the operating room with personal protective equipment on.
You mentioned preterm labor, which has come up in several articles. The other that has come up is increased stillbirth. And one of the things that we've been doing and others has been to certainly advise these patients of counting fetal movement and when necessary, increase the antepartum surveillance. The other thing before I forget is that we have the Florida Perinatal Quality Collaborative has collected data on cesarean deliveries, preterm labor in Florida. We did not see an increase. What we did see an increase in Florida was home deliveries, unfortunately. And that data is going to be, actually it was submitted for ACOG abstract. So the only thing that Bill Sappenfield, myself, and one of the other fellows found was home deliveries. There was a blip in home deliveries, unfortunately, but there was no increase in preterm delivery. There was no increase in cesarean delivery, and those were the two. So something to keep in mind.
So interesting. So the early reports out of China, I think about 90% of their patients were delivered by cesarean, and they were premature. But I think that's a very skewed view because they were so critically ill.
Correct. And as you mentioned, this was in the early days of the infection. And even I think some of the data from Seattle early in the days of infection suggested an increased rate in cesarean delivery. But I do believe now that we're months out, that the rate of cesarean delivery has not increased. I'm sure about that because some hospitals have had an increase in their NTSV weight, and we can't blame that on COVID. Now, if the we have time for questions, so you can either put them in the chat, or if you're polite, you can unmute yourself and ask your question.
Marilyn's raising her hand. But Marilyn, unmute yourself.
Marilyn, Marilyn is, I'll introduce her. Marilyn is the chair of the Healthy Start Board of Sarasota County. Marilyn?
Thank you. One of the questions I had is because I'm hearing a story from a friend whose daughter-in-law, it's a long story, but I'll eliminate all the relationships.
Thank you.
First trimester. If someone has COVID, how are we counseling them during the first trimester if they're receiving a lot of medications which may have a teratogenic effect on the fetus? Because the story that is going around in Brooklyn is that the baby was delivered with multiple anomalies, and that was due to the COVID. And my guess is it wasn't due to the COVID. It was probably due to effects of drugs that she may have received during the first trimester.
Pat, what do you think?
So Marilyn, that's a great question. As I pointed out, almost all the information we have to date comes from women infected in the latter half of pregnancy, where you weren't quite as worried about teratogenicity. I would think, well, one, we need more data, and two, in that particular patient, what I would do with that patient would be an ultrasound, a comprehensive ultrasound at 20 weeks, looking for evidence of anomalies. Certainly the genetic screening, that has nothing to do with COVID, but that would be reasonable at 10 to 11 weeks or so, the NIPS. But I think ultrasound is going to be the key there. And then serial scanning, maybe at 28, 32 to 34 weeks to look for long-term effects on fetal growth.
Just like
that brings up the whole counseling side of the issue and the mental health and everything that's playing into the effects of COVID in the community.
So the more we could reassure her with a comprehensive anatomy scan at 18 to 20 weeks or so, I think that would be very helpful in calming her angst.
Sure, thank you.
Pat, Marilyn does bring up a an important point, and there are many clinicians on this call, and that is the anxiety that many patients have about being pregnant and exposed to or a positive test to COVID. Can you comment a little bit about that, please?
Another great question. Most of my patients, and I just came from my private office, most of them are either physicians or nurses at the hospital. So this comes up literally every day. And so the key there is counseling about appropriate precautions that we just talked about. But one of them was pointing out to me today, she said on her floor, they divide patients into those that are clearly uninfected, and they knew that, and patients that they don't know. And one of the persons they didn't know anything about turned out to actually be infected. And so my patient had a exposure. So then frequent testing, initially, and then another one a week or so later as a follow-up. And, Washington, I don't know, without great scientific evidence, I've been telling my patients who work in that kind of environment that during the last 2 weeks, I recommend that they try to do something just administrative or just stop work. And I've written a number of letters for my other patients who are school teachers to get them out of the classroom into the Zoom arena.
Right.
I think the key is avoiding exposure. And if you are exposed, isolate, test frequently.
All the things that we've been told over and over and over again. Any other comments, please? Any other questions? You got the expert here now. Even though he's a Gator, you can believe what he says about COVID.
I saw one person in the chat had asked about references, and what I'll do, I'm going to send Sarah the up-to-date version of these slides, and I'll pull together a short reference list that I think has maybe the top 5 to 10 articles in the recent literature, of which there are hundreds, but I'll try to pull maybe the top 5 or so and send those to you as well.
That would be fine. Please don't compose an exhaustive list, but half a dozen or so would be perfect. As you mentioned, this changes all of the time. Anyone else who would like to unmute themselves and make a comment, please, or a question? So Pat, the pregnant nurse who is working in labor and delivery, since we know some patients are asymptomatic, what do you tell her?
Well, and I have several such patients, so I've told them, wear your mask constantly, wear it correctly, wash your hands thoroughly after contact with patients. If there's clearly a person who's under investigation because of symptoms or is known to be positive, let one of your non-pregnant colleagues care for that patient. And in any uncertain situation, full PPE.
Thank you. Any other comments, questions, fears, anxieties, other than the rest of the day?
Well, thank you, Washington, for having me.
Well, this has been my pleasure. And for those of you on the call, you will meet people who you will admire, who will be your mentors, who you can call. And certainly for me, Pat Duff is one of them. Pat, I sincerely appreciate your friendship over the years. Thank you to our sponsors. Remember that this conference is brought to you by the Healthy Starts of DeSoto, Manatee, Sarasota, and Charlotte County. I want to thank our sponsors, ACOG District 12 and Drug Free Sarasota. I wish you all a a peaceful and not too anxious rest of the day. Thank you very much.
Thank you, Washington.